Okay, thank you. I expect you, all of you were in Ljubljana at the meeting, and so I will not introduce Slovenia anymore. Just to remind you that we are the only country in Europe that has name love in the name of the country. Again. So I'm here on behalf of the actual two partners, General Hospital of Slovenj and Healthcare Center Ravne na Koroškem. My role is a subcontractor, and some people are more busy than the others, so they sent me to present you the situation. So we run two services. One is congestive heart failure service and diabetic service. Congestive heart failure services we run covers population of 80,000 people only. Among them, 3,000 are those with heart failure. We have a database in the hospital with somehow 800 people having the cardiac heart failure. So, our target is to include or to provide service to 200 patients. Currently, we have 92. And the model we use is displayed. So we have we measure weight, we measure blood pressure and oxygenation. We use also a mobile phone as a gateway, and we do have a physical center, telemedical center in the hospital. The important role here plays the family of each particular patient, so they are involved from the early beginning. Family members usually come with patient when we do training with them. So the situation with the diabetic service is the following. We are targeting population of 80,000 again. Among them, 4,000 are people with diabetes. Our target within the United for Health is 400 patients, and currently we have half of that, 200. They all have glucometers at home and also gateway, mobile phone as a gateway. So these are terminal devices we use. We have, you see at the left side, we have the quantity of expected number of devices the provider actually provides partial deliveries to us. So where did we start? No service at all at the beginning in the region before we started United for Health, but my company MKS actually has provided experience from 25 years experience in telecare. So I was somehow able to persuade the hospital and healthcare center to enter the United for Health society, and so then clinicians decided really to monitor two anomalies, two illness, but not COPD. The first thing we did was that we visited two existing telemedicine service providers, one in Italy and one in Austria, and both were members of the Renewing Health project. From the beginning, we have decided not to go for any development in this data transfer chain. That was the decision in the beginning. We have some development capacities, and we have done something to support from the technical point of view of the service, and I'll explain this later. The next decision was not to start working with somebody who will design the technology solution from the scratch. So we have decided to avoid those initial difficulties by selecting an experienced telemedicine technology provider. So we have started negotiations with Health Insight Solution company from Germany. And we knew from the beginning that we would need our own portal, web portal, to handle data. So the different kind of data presentation that suits the expectation and needs of the medical workers. And all three decisions were good, so we are still proud of that we avoided a lot of problems by that. So there was another issue at the beginning as well. Both the hospital and the healthcare center said we have no money. But if we enter, we should get enough money to cover the expenses for the equipment. What we are willing to do is to work, to learn something. And this is the initial, the start point, actually. So we have some difficulties for the moment because all the costs came at the beginning. But we have a little bit mitigate this by making a reasonable financial arrangement with the technology provider. We were aware of huge delays that may occur if you enter public procurement procedure. It lasts 1 year, actually, to go through, and you don't get what you want, actually, at the end, because usually the lowest price is the only criteria for selecting. Of course, there are some other excluding criteria as well, but when you have appropriate providers, and there's none from Slovenia, so there would be newcomers which wouldn't know, so we said no to such a solution. And so we have, we've been seeking for alternative legal ways to come to the technology. So we choose one which is legal, that a consortium was formed, was aiming at introducing telemedicine service to the region, and that would actually, its activity is to work further on beyond the end of the United for Health project. Yes, and so we have started to look around for a financial arrangement that would enable us to buy equipment. Before doing any agreement with the provider, we tested all the equipment. So we got a demo suitcase from the provider. We tested also the server capacities. So everything was everything worked before we entered the negotiation phase. And the fact is that one single supplier provides all the components for the data capturing and data transfer. Only minor adjustment had to be made to the existing technology solution of the Health Insight solution as a provider, and those were made during the test period, which was 2 months after the first, after the start. We have also agreed with the provider that we could use our own data processing tool so that data are forwarded from their server to our server, that we can process then our data in accordance to our needs. So we are not bound to the provider and his means of presentation data. We can act on our own. So again, most of the things turned positively in the financial, from the financial view and also technological view.
Drago, would you allow one question in between on the last slide? What I do not fully understand is how you said something here that I do not know what means FWD. Can you say something on what infrastructure is used in the health system by the clinicians? and where the telemedicine service links in there. This I didn't understand.
So could you repeat the question?
Is your telemedicine solution, is it an island, or do you have any data exchange with the hospitals or other healthcare providers?
No, for the moment we don't link our data to the existing hospital information system. We are still outside.
And do you plan to go inside?
Yes, of course, but first we have to know what we have in hands now, and what of what use such data could be for the clinical work. So the clinicians have to become acquainted to, or has to go through a process how they will use the data. Now we've been experimenting, presenting them data in different ways. So once they knew what they want to have in the hospital information system, then we will export data to the hospital information system.
Okay, thank you for the clarification.
Now they are used to look, let's say, into the diabetic notebook. They bring with when they come to see the doctor. They go through and they have an impression in which situation actually the patient is. But they are not used to look at the data presented in the form of graph and such things. So we wait until they actually profile their requirements.
Okay, thank you. So please continue. And
so there were some things to be resolved. Of course, hospitals are, as you know, institution. They are there, so patients come there. If they don't come, if they don't appear, there's no. They have nothing to do with such a patient. So now we extend our with our service. We expand our working place actually. So this was something different from the existing model. So clinicians were a little bit surprised what was that. So no having experience in reaching patients outside the hospital. Organizationally, they were not ready for such a new approach, actually. So there still are difficulties in the organization to accommodate actually the new service. But important for me is that key people, professionals, are involved and they are determined that we will have the service also beyond after the project ends, and we have strong support from the hospital general manager, and this is very important. So they come to our meetings as well, not today, but usually they come, and that's different from what I've experienced before. When managers were not interested in the work of researcher and developers. But we have to link with the IT sector in the hospital, and they are like kings on their territory. And if you approach to them saying, well, I need this and this, who are you, firstly? Then you will go into the queue. This cannot be solved within 14 days. It's too much. So let's say to get a virtual private network access to the server behind the firewall of the hospital, it lasted 3 weeks. But it's a 10 minutes job actually for that. So some resistance actually with the IT department in the hospital. So what our experience was gateway smartphones. So the dilemma is availability of the same type of mobile phone on the long term. So we have we have now 3 different types of mobile phones with, for these 300 patients. So when we start we didn't want to order 600 phones, so we have partial deliverables, but now every time we order, we get different device. It causes us some difficulties to maintain this, to prepare all the phones for that, to prevent some programs to work and such things. So we need to simplify also things, so remove some apps and so on. We would need some kind of locking of settings and somehow some reduction of functionality of the phones that they would serve just for our purposes. But this is not. This is in contrast to what people usually want to have. Many apps, many different. But there are financial consequences of that. This month we paid for one patient 150 euros because he played with the phone, and we have a very a package having only small data transfer amount paid with that. So it's not acceptable. So the other thing we have difficulties with smartphone is that they are not designed for to be used for senior people. So also myself, whenever I touch from which point, from which side, I press a button. But this, of course, if you are experienced, you come back immediately. But if you are not, then, well, our logo disappeared. So what to do now? Let us call the operator in the telecare center. Yeah. So we prepare everything so that the phone need to be only plugged to the electricity. So startup sets directly the application we have, and it works. If not, if something is not changed. So I've already mentioned data transfer cost, and our experience is that we should somehow be able to determine in advance which package to be selected or to with the mobile phone provider to reduce or to keep costs within the limits. For the moment, we pay, let's say, 600, 700 a month just for connectivity. The other difficulties is that every month the mobile phone provider sends an update. So updating is automatically, that means costs for us, or should be done when we receive the phones and we prepare the phones for the patient. Every mobile phone has to be updated, so that takes time as well. Also in our country, although the coverage is quite good, there are some poor coverage of the mobile signal, but with the mobile signal, but the application we have is such that even there is no mobile phone, the data are recorded in the phone and sent later when there is a mobile signal available. The request we have from patients is that we should enable them roaming when they go for holidays to foreign countries. Let's say to Croatia, we go low down, they want to be supported also there. So we have to handle this international roaming. Hopefully things will change within 1 year when Europe will be united in this. Okay. So from the measuring devices perspective, or for this view, so we have difficulties that our patients compare their devices, the results taken by their devices and our devices, let's say in glucometers, are not the same. They still keep their old glucometers and perform measurements 6 times a day, 6 times a week, but the 7th day the whole profile is measured for us, and the data measured by our glucometers are different from those they have. So, but the question is, which one is more accurate? So which is the reference, which makes some, which actually doesn't give accurate values. So and reliability of measuring devices, we have 10% drop-off with weight scale, so we have to send the devices back to the provider. Okay, recommendations. First, select the experienced technology provider for the key elements in the solution. Avoid public procurement. Find the local technology support for your service. MKS actually provide this, and think about post-project period. So ethical issues will be opened if we close service down after the end of the United for Health project. This is presentation of our data for the heart failure patients, and this is so apples are presented for diabetic patients if the measurement was taken before, and half-eaten apple if they are taken after the meal.
Okay, thank you.